Hey, this is I guess second part of gender-specific female. I'm going to cover pelvic inflammatory disease. This is a spectrum of inflammatory disorders of the upper female genital tract. We've actually seen a decline in it as far as being caused by sexually transmitted diseases, but it does still occur. And if you're suspecting or diagnosed pelvic inflammatory disease, all these patients, female patients, should be tested for HIV, gonorrhea, and chlamydia as well. Remember, not only sexually transmitted diseases could cause this infectious condition, but it could also be caused by endometriosis, salpingitis, which is inflammation of the ovaries, or pelvic peritonitis. So it can be caused by a lot of different things. Just to kind of get an idea. So what do they present with? Well, abdominal pain is the biggie. Usually becomes pretty constant. Can it be anywhere from mild, severe in the spectrum? Pain may be associated with intercourse. They may have cervical drainage. Report history of irregular bleeding or increased cramping when they have their periods. Now, one thing, when they look at criteria, they look at one or more to support the diagnosis of PID, pelvic inflammatory disease. They really try to narrow it down. So if your patient is febrile with a fever of greater than 101, they have cervicomucal purulent discharge. If you notice they have an elevated ESR rate and an elevated C-reactive protein in their blood work, that's an sign that there's an inflammatory process going on. The most specific way to diagnose this pelvic inflammatory disease is endometrial biopsy, or they will also do a transvaginal sonogram where they'll be looking for fluid-filled areas and thickening of the uterine walls. So those are kind of what they'd be looking forward to as far as diagnosing. Now, if this goes on, it can cause some pretty decent complications for this poor person. We do know that 1 in 8 women with pelvic inflammatory disease experience trouble getting pregnant. So that can really, impact a woman or a couple pretty severely and be very depressing or a scary event for them. They can also develop abscesses, strictures because of development of scar tissue. Those fallopian tubes can be obstructed, so it increases their chances of ectopic pregnancies. So we definitely want to make sure we teach these patients about the symptoms of ectopic pregnancy so that they know what's going on. Eventually, if it goes downhill, they can develop septic shock. So all not good for our patients, right? We don't like when they go into shock. So how are we going to treat the patient? Well, usually these patients are treated outpatient. It's usually a broad spectrum antibiotic combination that they're placed on, and they're monitored real closely. They're told to have no intercourse, rest, increase fluids. You also need to have the partner examined to make sure they're not going to cross-contaminate each other. And then you reevaluate them on a frequent basis. Now, if things don't improve, pain's out of control, sometimes they can be nauseous, vomiting as a result of the pain so bad, they need to be admitted to the hospital. They're going to be placed on IV antibiotics, corticosteroids for the decrease in the inflammation process. Heat to the lower abdomen sometimes helps. Sitz baths, I think sometimes they feel good for people, sometimes they don't, but they do say that possibly. And then they need to be evaluated for surgery to see if there's something going on, like an abscess that maybe needs to be drained. Do they need to go to the OR for that? Of course, they're going to be on IV fluids and pain meds as well. Very important to keep them as comfortable as possible. Now, other things that we might look at is the nurse has to provide support, not just physically, but also emotionally. Because can be, they may have heard horror stories, or if this is a young 20-something-year-old being diagnosed with it and they're looking forward to their life and thinking they're never going to have children. So we do have to be there for the emotional side of it as well. Definitely checking vital signs, intake and output, assessing their vaginal discharge, pain levels, encourage rest, healthy diet, and we want to minimize transmission as well. So when we're educating the patient, we're teaching them about preventing infecting others and protecting herself. How are they going to do that? Condoms. Need to use condoms. And then they also need to know when to call the doctor. So when they go home and maybe they're experiencing worsening symptoms, they need to discuss that with and be able to understand when to call the doctor when those things occur. So it may be the development of the fever, notice change in their drainage, increase in the pain level, okay? Those kind of things. All right, so if pelvic inflammatory disease gets real bad, they can need a hysterectomy. And we kind of talked about this in the earlier slides as well. You can have a total hysterectomy where they take everything out. They take the uterus and the ovaries. If that happens, lots of times they need, especially if they're young, they'll need some sort of hormonal replacement initially. You can have the procedure done lap, vaginal, or abdominal. So it all depends on what's going on. Most of them are done, I'd say laparoscopy now more than anything. Vaginally, probably more so. All right, so another thing you might do, or we're going to do for our patients is we always got to look at those nursing diagnoses, right? So one of the things that we may be looking at is anxiety. Say they've just been diagnosed with cancer, and that's why they're having their hysterectomy. Maybe it's anxiety related to the pain, or possible perception of loss of femininity or childbearing potential. You know, some people may be thinking I can never have sex again because I had a hysterectomy. Or my husband doesn't, or my partner doesn't want me anymore because I had a hysterectomy. So there's a lot of things that can play into it, and that deals with body image and all. Acute pains definitely post-operatively, and deficient knowledge. I mean, any post-op patient, you know, unless they're a nurse like us, even us, when we take on that patient role, we can kind of lose some of our knowledge, but we always need to increase their knowledge base. So what are we going to do as far as nursing interventions? We're going to check the dressing sites. If they're a lap, we're looking at the lap sites. If they're an abdominal hysterectomy, we're looking at the abdominal incision. Always monitoring vaginal drainage, assessing for urinary retention, because remember we said that they are at risk for that. Assess for flatus. Why? We want those bowels moving again. Checking bowel sounds. Abdominal distension. Could be a sign of urinary retention, right? Especially if they have tenderness in the suprapubic area. Prevent DVT. How are you going to do that? Ambulate. Foot exercises. They may be in compression stockings. They may have SCDs on. If they're experiencing grief, we're going to offer support. Maybe, you know, offer pastoral care to come up and talk to them if that's something that they're comfortable with. Those kind of things. What to expect post-surgery? We need to constantly re-educate them about that. You know, what are their activity requirements? What can't they do post-operatively? What can they do? If they're going to be on hormone therapy, we want to provide education about that as well. And just just certain limitations they might. And remember, the limitations are going to differ depending if they had a vaginal hysterectomy, an abdominal one versus lap. So it really depends on what type of surgery they have. So what are potential complications that they can have? Well, hemorrhage would be a biggie. And we had one of those in the first slideshow about that exam question about that person experiencing signs and symptoms of shock. So definitely that's a biggie. DVT, post-op patient, always at risk. Bladder dysfunction, we talked about that. And infection with any type of surgery, right? We're looking for signs and symptoms of that. Here are just some things we could do for our patients. Anxiety, what are we going to do for them? We're going to allow them to express their feelings. You guys are in psych, you know about that, right? Not going to pass judgment. We're going to be there as a listening ear, clarifying things that they're saying. Body image, again, address sexual concerns, issues, approach and evaluate each patient differently. Each person is going to be so different how they react to this. Some people may be thankful, my God, I won't get pregnant again. I'm done with kids. And some people it might be, I wasn't ready for this. I didn't want to lose that part of me yet. So we have to figure out where our patients stand in that. Definitely part of the nursing issue is we're going to watch for complications, right? So think about it. Hemorrhage, what are we going to watch? Blood pressure, vital signs, right? Obviously, we're checking vaginal drainage. If we see an increase in that, that could be a major sign. The other thing is venous thromboembolism, a DVT. What are we looking for? Tenderness, unilateral tenderness, swelling, redness maybe. Not always, but sometimes, right? Bladder dysfunction. Maybe they're holding on, not emptying their bladder completely, or maybe they're retaining a ton of urine, right? So we definitely want to be able to assess that and get a good idea. We might use a bladder scan for those patients. Maybe. Okay? Teach them about self-care, incision care, maintaining bowel and urinary function, how are they, resuming activities. We want to educate them to take showers instead of baths initially. What activities to avoid, what symptoms to report, when do they go see the doctor again? All those things are critical for any patient going home after surgery, right? We really need to make sure that they can do all that and understand it too, because if they don't understand it, gosh, it's just not going to help us at all. They'll just end up back in the hospital sicker than what they were from the beginning, right? And we don't want that for our patients at all. It's not where we want them to be. All right, so that's it. That's the last female.